Thank you all for joining today. Welcome to the session. I see many of you are joining slowly. Thank you for joining. So my name is Shilpa Sadanand. I have my colleagues from the Resilience Collaborative team, Varadarajan, Ashish, Prachi, Sushri, and Nikita were also on this meeting. Thank you for joining. Why don't we get started? Welcome again. Do let us know where you're joining from. Add an emoji that represents your current mood. It might be early morning for someone. It might be late night, a few of you. So where are you joining from? You could unmute yourself and let us know, or also type in the chat. And what's the first word that comes to your mind when you think of mental health and well-being? I see some chat responses already coming in. Neelam, hi Neelam from India. Thank you for joining. Hello, Dr. Ashi from India. Hello, Elred, joining from Canada. Apologies if I've misspelled your name. Thank you for joining. Ainda, welcome. Joining from Bangkok. Thank you. From Myanmar. Thank you for joining, Emily. Hello, Carla from Philippines. What's the first word that comes to your mind when you think of mental health and well-being? Do type in. Happiness. That's a great way to start the session. Thank you. Anyone else who want to take a... For me, mental health and well-being is about how I manage my work, empathy. Hello, Chala. Learning. Great. Resilience. Excellent to see that. Thank you. Calmness. While the responses keep coming, I'll get started, but would love to hear your thoughts on this slide. So do type in, so what is the first word that keeps coming to your mind when you think of mental health and well-being? With that, let me get started. My name is Shilpa Sadanand. I'm a program manager at the George Institute. We are a part of a team called the Resilience Collaborative, a global community of practice, which works for healthcare worker well-being. In today's session, I would be briefly covering a little bit of background and as to what is the objective of this session. And my colleague Varadarajan will walk through the TRC Toolkit, which we have developed along with many healthcare workers across different regions, and then open space for discussion. What are the outcomes from the toolkit, utilizing this toolkit, and in the end, a few key takeaways, and also, the ways you could get involved with TRC, and any feedback you might have. We also have a few TRC members who have joined this session, who would like to talk about as to their interaction with the TRC toolkit itself. With that, let me go on to the next slide. So a little bit of the context. So yeah, so the objectives is to, kind of emphasize that, CHW mental health is definitely a priority, and also recognize the factors that influence their mental health. What could be a practical, or a practical strategies to initiate mental health and resilience conversations in the workplace using the TRC toolkit, and also equip some of the participants to apply the TRC toolkit components to promote mental health within their own workplace settings. So a little bit of the context on the resilience collaborative. So before that, let me talk about the George Institute. So as you know, the Resilience Collaborative is a global community of practice. And as a George Institute of Global Health, we are the secretariat of this community of practice. So George Institute was birthed in UNSW in Sydney in 1999, and we have presence across different regions in India, China, and the UK. We are about 1,100 people across regions, many projects in about 50 countries, and we have academic partnerships across different regions. Our mission is to, improve the health of millions worldwide, and with the Resilience Collaborative, the focus is on healthcare worker well-being, mental health and well-being. Moving forward, so what are the challenges? We know that there will be a shortage of 11 million healthcare workers, primarily in low and middle income countries. These are the latest WHO estimates. Increased stress, burnout, skill shortage, decreased productivity and retention, keeps happening. And according to latest reviews, it is shown that, targeted, well-designed mental health interventions can improve outcomes among healthcare workers. So a little bit about the collaborative itself. As I mentioned, we are a global community of practice to advance learning and drive adoption of evidence-based strategy for healthcare worker resilience, particularly in low resource settings. So how do we do that? Support their well-being, preventing burnout, and also improving the quality of care in under-resourced settings. So the George Institute serves as the hub and also the host organization for this global community of practice. So the aims is to advance equitable quality of care by prioritizing the well-being and resilience of healthcare workers, and also the systems they support through leadership development and capacity building. In the long term, institutionalize TRC so that it can sustain process ownership and also continue to support frontline workforce. Strategically disseminate some of the research work we do within the collaborative to enhance healthcare worker agency and also influence policy. Some of the partners whom we work with, Reach Digital Health, who have with the Resilience Collaborative, who actually implement the WHO Health Alert. It's a digital solution, a simple WhatsApp-based solution for healthcare workers to improve well-being. Dimagi is another partner whom we work with. They have a WellMe, which will do part of implementing in India and different regions in Africa. It's again a digital solution to improve well-being of healthcare workers. We also closely work with Access Health International and also the Global Learning Collaborative Health System Resilience. So, and the assets we would be focusing on today is the toolkit itself for the program managers and also the healthcare workers to initiate conversations around mental health and also think about what they could do for themselves and within a group for their managing their mental health. So a little bit of the toolkit itself and what has been the process over the last few years. So going back to the history, so the initial TRC toolkit, which was developed by the Johnson & Johnson Center for Healthcare Health Worker Innovation way back in 2021. This toolkit was particularly for program managers or organizations to support the employees' well-being, which enables them to continue to deliver high-quality healthcare to vulnerable populations across the globe. So this toolkit is also available on our TRC website in the resource section. You could always go back and have a look. So that's where the toolkit started. It also has a evidence library till 2021, also has measures library, different aspects of resilience and mental health factors. Uh, so in 2023, 2024, when we, the George Institute, took over as the secretariat for the Resilience Collaborative, we would want to update this toolkit. So we had a series of workshops, one workshop with different mental health experts in 2024, where the key suggestion was that, the toolkit should be updated along with the healthcare workers themselves. So this year in 2020, Feb 2025, we met a group of, and we continue to meet a group of healthcare workers to understand as to what do they expect if they have a toolkit for their mental health and resilience. So, and we continue to update the evidence and measures library. So there is ongoing evidence synthesis work where my colleague Prachi, who's joined the calls, leads the work on two systematic reviews to build the, what is the current evidence to which will add to the TRC toolkit. So the overall, what is the process that we have followed? One is, developing the toolkit itself. We're currently validating the content and the process. And then as a next step, we will validate for the outcomes. So that's the subsequent steps we plan to do. So these are some of the pictures of the validation exercise. As we are based out of India, we've been able to continue to meet different group of healthcare workers across different regions. Ramnagara is in southern part of India, Siddipet as well. And we also had the opportunity to meet a group of health workforce in Maldives. This was a private hospital where we met about 70 participants. This was recent. We also met a group of community health workers who work in the tribal region. This was very recent, about 2 weeks back. So we continue to hear from them, and we continue to get the reports out, and we would be happy to share some of the findings from these exercises. So this has been the journey. So from 2021, the different consultative workshops. We also have the report from the first workshop which we had with the healthcare workers in Ramnagara. What were their understanding, and finally the toolkit which we would like to discuss today. Where where anyone could actually use this or adapt this toolkit to begin mental health conversations in their own workplace settings. So this is what we will focus on. I know that I took a bit of time to give the context, but now I will hand over to my colleague, Varadarajan Srinivasan, to speak about the toolkit itself. Over to you, Vardu.
Hi, welcome everyone to the session. We are extremely thankful for you to be able to make time for this. We hope that you find a lot of value to what we are to present, and we really encourage you to see how you can use this and take this forward. Can we go on to the next slide, please? Yeah, so this has very specific sessions. The manual that we have currently has a very nice process that has been detailed, and at the end of every process we have very clearly set saying that what would be the outputs for this process, and what are the participatory methods that you can use for these processes, and so on. The whole toolkit sessions, or maybe the sessions that you will have with the community health workers, begins with the introduction itself. So it's not a simple introduction of just people alone. This is where I think the whole conversation on the resilience and mental health begins. So we find this the most exciting part of our entire session, as this is where we often discover that the health workers may not necessarily have similar constructs to mental health and well-being like what we do. especially when it comes to resilience. In many cultures, there are not equivalent even words or conceptualization of resilience as we understand as professionals who have been exposed to this whole idea of health workers and health, mental health and well-being. So, this session we effectively is where we start that discussion on understanding what they really conceptualize this idea of mental health. I think culturally it becomes very important to have a session like this for basically for us to be able to align ourselves with their ideas rather than enforcing our typical understanding of what we think as it and trying to pull them up to that pull them up to adhere to those ideas. I think we found a lot of value in this introduction, and this sets the tone and builds that rapport immediately, even if they are a new group who are interacting with you, to be able to immediately connect with the topic. And one thing they all immediately are able to appreciate is that this is not a typical session where somebody is coming and training them something related to their work, and there will be outputs that are expected and so on. And this is where they immediately are able to connect, saying, hey, these guys are here to talk about us. And that we found was very powerful, and it was universal across all the places, maybe in India, maybe in Maldives. We could really appreciate, and they were able to immediately appreciate, saying that I think this session is important for me because they are here, or maybe, this session is all about me and not about my work or so on. So I think that sort of synthesizes what we try to do within the introduction, or what the process is set for, what typically happens within that introduction session. So then we slowly move on once the stage is set, once this context is set, we move on to the next session, uh, which is uh, uh, which is about the stressors and the whole idea of what are the various mechanisms that they use for resilience, and what is that they mean by well-being and so on. So this is like further sort of inducting them into the discussions. These are largely participative. That is what we have realized, saying that we don't use presentations largely. These are just plain charts, and any methods that they adopt to or they want to express themselves with is something that we allow, and it naturally sort of evolves. And we tell them, say, how is that you want to represent this, how is that you want to understand or discuss about this. Largely it's even discussion within the team members that we have seen comes out with a lot of data, or not just the data. What I mean is the conversations that yield the information around the stressors that they go through. So and this session eventually sort of captures or help them sort of refine their thoughts around stressors. And what we have done is the toolkit sort of follows a socio-ecological model where we think about all these stressors or all these coping mechanisms or all these system level changes that we want to see at three different levels: at individual level, or the micro level we call it, and the family or the community level, or the meso level, and the system levels is what we call the macro levels. So every single discussion that we do ultimately get organized in the socio-ecological model for a better understanding, so that the solutioning can be better. So that's the idea that the session 2 is all about. It is them talking about their stressors that they go through, and they immediately pick up the cues, like saying, hey, yes, yeah, stressors is not just about us being stressed because of ourselves, but we see that there is a lot of influence of the family on the way we experience stress, or that the family or maybe the others had stress too. And it can be because of the co-workers in many places, that they realize that they are also a potential source for stress, and so on. And also they immediately are able to recognize the stress that comes from a larger system, may it be within the organization and their policies as a system, or probably even the public health systems at large. So this session essentially captures it and triggers the discussion around this. Yeah, can we move on to the next slide, please? Yeah, so this for example is the stressors identified by a private hospital in Maldives, where there is a predominant expat population that works as health professionals there or health workers there at all levels. We also interact with the local professionals who work along with them. So it's a very interesting dynamics that happens, and it's very different the way the stresses are experienced by the local professionals who are from the place, and whereas the people who are expats who often come from other countries, nearby neighboring countries, and who just are mostly alone without their families and so on. So this is the example of synthesis of what they came up with, us what they identified as most important stressors. And you can actually refer these reports back, and it's all there on our websites. There we have where we have put up these reports, which actually synthesizes the discussions that has happened, or probably the way they have discussed it and come out with these. So for example, if you see, like, saying that at the individual level, when you open up these discussions, even if the management members are present within that discussion, they are able to actually conceptualize and put it in a way saying that yes, workload management is poor in our hospital. So that leads us to stress. The way the shifts are organized, and all of a sudden we are called for our work, also leads us to a lot of stress, and so on. So it just breaks that barrier and enables as a platform for them to be able to bring these issues up, which enforce which till that point they necessarily don't discuss before the management and so on. And moment it is becoming a report, and if it is being able to be presented, then there is a buy-in for the management to even look at it and say, oh yes, yeah, these are the major barriers that they appear to be having. So how is that we can address few of them, and then start the solutioning process from there. So that's something again nice that we have noticed. Or this is just an example from how the discussions translate into meaningful advocacy tools for the health workers to go take on with whichever level they want to. Can we move on to the next slide, please? So this is the way, like, if you see that these are like ASHA workers in India. ASHA workers are volunteers at the community level, who are essential part of the public health system, but they are still volunteers and not a formal employees of the public health system per se. So when they have relatively lower levels of education, and they chose saying that no, we will represent it as drawings of what we do in a day, rather than just contextualizing and putting it into a table. So we allow, the toolkit allows such spaces, or maybe allows such freedom for them to be able to express in whichever way they want. The picture you see is what they have drawn, are conceptualized as their stressors and where the stressors come from and so on. So that's something that the toolkit encourages, saying that use any media that they are comfortable with. Can we move on to the next slide, please? Yeah. So the next session within the toolkit is where they talk about the stakeholders, saying that how do they contribute to building the resilience, and how is that they influence. These are the stakeholders who become critical and key part of the solutioning as we move forward, because they are the ones who have the maximum influence on their well-being, and they certainly can contribute to resilience. Again, we can see the details of the various way of how they felt that the other stakeholders had an influence on them. These stakeholders, they identified from anything between family members to the people who they work with, or to the people who they elected as politicians, and the policy makers and the implementers and the management and so on. So they are able to decipher that and break down those key set of stakeholders, and say, I think this is probably a key stakeholder whom we have left out. Even at the community level, the elders of the community, and if they are a tribal community, they have very specific people who leads that entire tribe, or maybe within a village, the person who leads them. And they identified all these people as probably who can help build resilience in them. So I think that helps us so much, or helps them so much, in being able to identify solutions, simple solutions, because these are the people that they can involve them in the process and so on. So that's the next session about. Now, can we move on to the next slide, please? Yeah. So what happens to all this, like session 1, 2, and 3, is what it translates it into a simple table like this. So we have just given one example for how they identify different stressors or different coping mechanisms. Along with stressors, actually, we also in session 2 discuss a lot of coping mechanisms of saying that no, what is that it makes them to come back to work for after such a stressful day. The next day they again all turn up invariably. So no, how is that they cope up with various things, and what are the individual level mechanisms, and how is that they effectively use the family to cope up the stress that they experience during the day, and so on. So this is what it translates to into a table at this stage after session 1, 2, and 3, where essentially they have identified all the stressors and tabulated it, coping mechanisms, tabulated it, stakeholders, tabulated it, and probably if there was an intervention, what would be the features of the intervention that they would like, is what it translates into all these discussions. It doesn't may take much time. So what we have typically seen is the people are able to put it down in a table itself in some places to begin with. Moment we expose them to the entire toolkit, they said, no, it's easy for us to start tabulating it directly. Or if there is a person who's facilitating the whole thing, the person was able to tabulate it immediately at the end of the exercise without taking too much time. So that is session 4, what we call the data synthesis. They all sit together and do it, or maybe if there is a facilitator who is leading in a context where the people are struggling to do it, somebody else does it for them. So can we move on to the next slide, please? Yeah. So what happens to all this data? It doesn't stop there. The session moves on to a next phase where the actual solutioning happens with them. I think this was the most exciting session for us as the people, because I think this is what the toolkit intends to do, for them to be able to identify and start little work around building their resilience by themselves. Like invariably when we say that what is that the coping mechanisms they use, they come up with a lot of ideas themselves. Say this is what. Sorry, Ashish. Yeah. So there is a lot of individual level exercises and group level exercises and community health level, level exercises that they already identify as something that helps them build their resilience. So now they are translating it into meaningful interventions. So that is what is the beauty of this session, where now whatever they have identified as the potential solutions that they use is getting exposed to a larger group, and they all agree saying that okay, fine, these are certain activities that we can start as a group or as an individual, and these are the resources that we need, who can support us in this journey, is something that they come up with. So ultimately they come up with a table, and currently the toolkit we are discussing about two levels of solution. One is at the individual level, and one is at the meso level, where at the family or the community level is what our solutioning stops at. We still haven't got into the stage of building up solutions at the system level or for the advocacy at the system level. What we believe is at this stage, if they are able to adhere to this and be able to effectively use the solutions that they have developed for themselves, moving forward, this becomes a great advocacy tool and builds that agency within them for them to be able to build solutions for the systems as well, and to be able to advocate for it. So that is the trajectory that we do, a trajectory that we see that this toolkit might help the CHWs with. Can we move on to the next slide, please? Yeah, so I would really like you all to hear some of these stories. I think this is the inspiration that takes us back to the field again and again. So this is voices from the front lines. Yeah, we can start the small clip that you can all hear.
Just let me know if it is working fine.
Yeah. I don't think we hear the voice, Shilpa.
జాగ్రత్తలు చెప్తారు. ఎలాంటి ఆహారం తీసుకోవాలంటే ఇంతమంది మనం ఒక రోజు బయటికి వెళ్ళి వర్క్ చేయడం వల్ల ఇంతమందిని సేవ్ చేయాలి. ప్రతి విషయం ఏదైనా పెద్దగా ఆలోచించకుండా ఒక 10 నిమిషాలు రిలాక్స్ అయ్యి అసలు ఏంటి మనం చేసే పని, నేను ఎందుకు ఇంత టెన్షన్ పడుతున్నా అని కొంచెం ఆలోచించుకొని చేస్తే ఏ పనైనా చాలా సులువుగా చేయగలం. కానీ ప్రతిదీ టెన్షన్ తీసుకుంటే ఏది మానసికంగా గురైతే మనకి ఆరోగ్యపరంగా దెబ్బతింటాం. అన్నిటికీ
Yeah, so that was just a representation of saying that when we go to the field, we do have these inspiring stories of community health workers who have probably just fought all the odds that are really against them, and to be able to thrive and to see them build their families and they build their future is very moving as well as very inspiring. And we come across such stories quite regularly when we go and do these exercises across many places. So that's something that I would all encourage you to. It's not just about the exercise. You get to hear a lot of inspirational stories when we roll this toolkit out. And what exactly were the outcomes that we were trying to achieve. And I think it largely helped us achieve these outcomes in many ways. One is creating that very creative space or open space or a safe space for people to be able to discuss or begin conversations around mental health at their workplace. I think that was one of the major outcomes that we were looking for. This triggers that whole idea of beginning those conversations in their workplace in a very safe manner. And it was very, it was very moving for us to learn that when we talk about themselves and their own mental health, especially the ashas and the community health workers, they find it very difficult to comprehend that they need to take care of themselves as well. They appear to sort of have internalized the whole existence of them for either their families or for the communities or for the PHC that they work for, the primary health care center they work for, or the communities. It was very difficult for them to think about saying that why is it important for them as individuals to take care of their mental health as well. And that was pretty moving, So, but I think by the end of this session, they all were able to appreciate, saying that no, unless I am healthy myself, I would not be able to do that. Can we go back to the earlier slide? And we also see this as a useful tool for advocating for their health and well-being. We remember saying that in one of the places where we had an entire range of health workers, including a doctor who had a lot more influence of saying what could happen within that primary health center, and they are able to discuss and negotiate that with them, with the doctor saying that can you just put in a room for us to rest when we come back from the field, and so on, right? So it becomes a useful advocacy tool, certainly. And that whole conceptualization of them understanding and breaking down their stressors on saying what exactly is causing at the stress and at what level and how is that we can deal with it opens up a whole new journey for them ahead in terms of being able to able to use this tool effectively to be able to build their resilience. I think that's been a very positive experience with deploying this toolkit. And the best thing is, like, the toolkit is so fluid, so it helps you adapt to any context. And we have now seen, like, right from the community health worker to a specialist like a plastic surgeon or a dermatologist have been able to find value to this toolkit. And it is and it has been used in completely different contexts, like a tribal NGO and hospital, to a government hospital, and to government community health workers, to a private hospital, and completely different professionals across. And we find everyone found value to this, and they were able to quickly adapt the things that they want to within the toolkit. So it's pretty fluid, it's not very rigid, so that allows you to be able to roll it out in any place that you want. Can we move on to the next slide, please? Now I will stop here. I think I've been talking quite a bit. So now I want you to just think on saying that of all that I have spoken, two things that appeal to you about this toolkit. So saying, yes, I think this is something that I may find it useful in my context, or probably I think this will be very exciting for me to learn from the health workers with whom I work with. And also the second question is saying that if you had to deploy this toolkit in your context, what do you think could you additionally include it into this toolkit? Or maybe what are the adaptations you think may have, will be required, or even modifications that you may want to do? So this toolkit is certainly available on the Resilience Collaborative website. It is free for you to download and use it the way you want it. And if possible, if you are able to give us feedback upon that, and you become natural co-owners of it, that has been one of the additional exciting things that we have included in this journey. So whoever has participated in the deployment or the adaptation have naturally become the co-owners. So we have all the people who have participated with their consents. We have put in all the names, and they all are the co-owners of this toolkit now. So that keeps growing by day, and you all are welcome to become a part of it as well. So I would really like you to reflect and type it in the chat box. These couple of questions or reflections from your end. And then I have Ashish Manwar, one of our colleagues. So he will discuss with you all of saying what is coming out from what you type.
We would be happy you could also unmute yourself and speak.
Yeah.
It'd be wonderful to see you and listen to you. So feel free to unmute yourself and let us know. And if any other thoughts you might have while we spoke about the toolkit, we'd love to hear from you.
I'm not sure whether it allows you to unmute your videos. Please feel free to unmute your video. Show yourself on the screen. So that will be exciting for us to see all as well.
Hi, I'm from Myanmar in Orchid. Very nice to hear the presentation. And then when it comes to resilience, we used to think of what you call people, their own resilience towards what has come to them. You see, this is the workplace. And then I like the idea of the collaborative, the resilience collaborative, so that it has become many answers to their own problems, you see. So this is very good. But one thing I want to ask is that in your toolkit, do you ever consider, for instance, in Myanmar, we have a very bad earthquake last March in Mandalay. So people there suffered a lot of mental stress. And then with that, you see, a lot of mental health people are helping them with the INGOs and NGOs and everybody helping them. But you see, there needs a lot apart from this kind of what you call supportive from the community as well as from the government as well as from the people themselves to be resilient. So, what do you have any idea in the TRC toolkit how if there's a kind of a disaster when it comes in the workplace, maybe even or the CHWs, maybe how do we help? Thank you.
Yeah. I will note that question down. Let us see whether there are other questions and answer it all together. Okay, while the questions are coming in, probably I can answer that question. Thanks for that question. That's a great question. So certainly we are looking at being able to deploy this toolkit for quick solutioning of interventions which are required in such acute situations, especially disasters. I think one of our colleagues, she is able to write a whole proposal for working on this particular aspect. We are looking at flood prone area where she will be exploring her thoughts on understanding, saying how these people experience stress. So we do recognize that disasters are one of the critical events that really exposes and makes our health workforce very, very vulnerable. And we would be happy to collaborate with you to be able to deploy this toolkit at your place to understand that nuances as well. And please feel free to use and have a discussion with them and see what is that they need as support. And one thing that we notice also is saying that once they are clear about saying that what are the simple things that they can quickly achieve results with, then it becomes easy for anyone to be able to advocate on their behalf or let them advocate for themselves on saying very specific things that they might need to address their mental health or the acute stress that they experience is something that we have seen as well. Does that answer your question?
Okay, thank you. Yeah.
Yeah. Thanks so much.
There are two more questions on the chat box. The first one is, how much time does it require for each session to be effective? And does it require regular follow-up to see the outcomes?
Yes, I think again, Lynn, it's a great question. When we started, it took almost a day for us to complete this exercise. But now the minimum we have done it is within 2.5 hours to complete the entire exercise. But the 2.5 hours, I will come up with a caution or a flag that it was like highly skilled professionals who are like, like at least having a professional degree in healthcare. So I would say anything between 4 hours with a break in between works really well, and it allows them enough time and space for them to be able to discuss everything. So 4 hours is what I would recommend at minimum. But if they want it broken further down, it can go probably across 5 hours with a couple of breaks in between. So that has been our experience so far. But in all the places, in spite of the 2.5 hours or a day, the outcomes appears to be similar. And as for the follow-ups, yes, I think it will be good to have that follow-up mechanism set up right in the beginning, which again is is something that nudges them to keep at it. It doesn't mean a regular visit or a supervisory visit. All we need is go back and ask them their stories of saying what happened since then and what is that they have experienced. And these people invariably collect together quite often. So what we do is we use such situations where they are coming back to meet for other purposes and make this as part of that agenda where we said, hey, we had this discussion, what has happened since then? Have we started celebrating birthdays together, which they identified as an intervention? Or no, have you got the cot or the bed to sleep at your workplace and so on? So that follow-up is required, and it's not very intensive follow-up that is required or a regular monitoring system, but it really helps them to nudge. As for the students, yes, yeah, we haven't deployed it amongst the students so far, but we see it might be helpful for them to get exposed as students to this whole idea of resilience, especially the health workers or the health workforce, the students who are likely to get into the health workforce. And but it should be applicable to them as well, is what we certainly see. It is just that the context of them staying as students is likely to be very short in a college. So I'm not sure how, or maybe it still should be able to, reflecting upon quickly saying, yes, I think it is able to. We are currently working upon a separate intervention, developing an intervention and co-designing an intervention for students alone who are getting into health workforce with one of the schools. We are in the conceptualization stages of it. And if one of you is interested, please do reach out to us. You can also become part of that entire effort. This is a large university, hospital, and health sciences college in India, whom we are planning to work with. Yeah. I think there are a couple of other questions as well. Hi, Eldred. Yeah, you are more than welcome to reach out to us, Eldred. No, it'll be wonderful for us to do this work in Cameroon. That is another thing that is not mentioned here. We are actually making an adaptation and deployment in Zambia over the next 2 weeks, actually. So that will be the toolkit's first footprint in Africa. So we would love to add Cameroon onto that list as well. Not for the sake of adding it, but at least to be able to create that impact amongst the people whom we work with. Yeah, and working in a hard reach area and humanitarian settings for the last 12 years, stressful for me. Again, you have been part of our team as well, Rita. So just looking at that whole idea of saying that how is that we can use this tool effectively as an advocacy at the higher levels is something that we would want to progress. this is the first stage of deploying this toolkit, and certainly we want to move forward and make sure that we are able to use this effectively as an advocacy tool with the advocacy tool for the systems as well. So that I think will be wonderful if we are able to work with Rita and make those results, and deploy this toolkit and come up with that entire solutioning bit, and then take it up and see what the policymakers are like. We are in discussions with one of the regional governments where we are having this policy discussion with them based on the reports that are coming out from there. So that is our first effort, to be able to take it up for discussion with the policymaker and the systems per se. So we really hope that it will sensitize them on understanding, saying what the real stresses are, because it's not it's not just purely an evidence generated from a larger complex systems, but it is their own, which they can feel and which they know that is reality there, and now it is in a form that they can consume. So we are looking at that discussion. Yeah, Ashish, do you want to take some of these questions, Ashish?
So which one are you?
If you had to deploy this toolkit in your context, and what might you modify? Okay, so you can take this bunch of questions. What modifications do you expect? If you have to deploy this in your place, or any of the other questions also, and Ashish, if you want to answer something on the other questions, yeah.
Sure thing. Yeah, please feel free to unmute yourself and make your comments, or if you feel comfortable to put it on chat, please continue to do that. We're interested to see what might you change or what might you want to include in the toolkit, so it becomes relevant to where you are or what the people you serve among might need. That's one question to think of. Many people that we work with also say, is it possible to translate the toolkit and the entire process in their local languages? And we are working towards that. We are going to try and do this in a bilingual format as much as possible, so it's easy for the people who are in the care setting to be able to adapt it. But if you're interested, please let us know, and we're happy to have that facilitated in your languages of where you are. Please don't be shy. Please feel free to put your thoughts, even questions on the chat, or raise your hand. Keen, please go ahead.
I'm Kinsa Lin from Myanmar. I am not sure if this is a question or a comment, but I'm wondering, like in our context, there are many areas where there are conflicts. So many of the stresses comes from the instability. So I'm wondering, only this kind of session alone would give them like relieve their stress. Like, should we also consider some kinds of like security measures included in this tool, or I don't know if that should be a different tool for them. So that is one thing I'm wondering, because it comes from a kind of political context where they are stressed. So it's not just the work stress. So that's my question or concern. Yeah, thank you.
Thank you, Keen. I think this is a really crucial question, and I'd like for us to open this aspect to all of us who are here in the thing. But our quick response is going to be, this is fairly relevant to humanitarian settings or settings of conflict or disaster as well, but particularly areas where healthcare workers feel unsafe or unable to address, some of the reasons or aspects that make their work and their families unsafe. This is proven in many places to be a very vital place to, or an avenue to begin conversations where things that are so suppressed and the absence of safety at least brings it out in a safe environment for people to be able to highlight or surface areas of their needs. So we tend to gather groups where there is a sense of psychological safety, but in areas where there, like you're mentioning, Keen, that there are challenges in terms of security or safety, we also want to make sure that we are sensitive to include some of those people who are probably helpful in the area of mediation or income sort of support for dialogues. So we certainly feel that there is a way to engage with this, but we are led and guided by the folks who are on the ground, who know what are the boundaries of safety, to what extent can we actually on these things. But all that to say, this is relevant to that and led by folks on the ground. Pardhu and Shilpa, if you want to add anything, or anybody else, please feel free to jump in.
Yeah, Lynn, see, the idea of again this toolkit is, Lynn, for them to be able to come up with solutions, right? So that is what actually builds the resilience. The toolkit per se doesn't have a say in it. No, it just helps them trigger in a right way the thinking, channelize their thinking, and come up with those solutions. What we believe is, like, if we deploy, what I would foresee, or probably what we can expect, or what we can nudge the conversations around is, when they are thinking about it, no, this is getting clearer. No, so far that fear that people have because of that instability might not be openly discussed. It might be at the individual level they experience it and they struggle with it alone. And what happens all of a sudden is, if they realize that everybody is struggling with it, why don't they just put it down on paper? So, and when they are able to think about it, say, hey, how is that you can make us feel secure? Maybe post somebody at the health center, some security person, whatever it is, they will definitely have a solution. Wish we had this, so that we need not feel insecure this way. We don't know how much will the system take it and be able to respond to it, but at least it helps them come together and conceptualize, saying what could be the potential solutions. That becomes a great start for facilitators like you to be able to take up as a meaningful advocacy tool. So that way I think we can influence it, saying that it is not one person saying or one person's feeling anymore. The whole group feels about it. There are 200 people saying that they feel insecure. Can we do something about it? So I think that is where the resilience is being built. And one thing that we also see is that one of the greatest inspirations and the resilience is built by the team themselves. Often we see that in the field, not in this exercise alone. Now it is evidenced as well that entire peer support mechanism that they have developed over the years, especially from the COVID, appears to be one of the strongest building mechanisms, resilience building mechanisms. How can we use that mechanism to keep them or maybe experience that camaraderie, where they are feeling, saying, yes, no, we are not alone in it. There are other people and we can support each other. I know that this is not enough to address their security issues, but hopefully this collective and collectively thinking together would be able to help them break down exact solutions that they may want to feel better. And that is where the resilience comes from, not just at the system level, even at the individual level, and even at the meso level or the organizational level or the family levels. The solutions that they come up with, if we are able to activate those solutions even in smaller ways, it is a journey for them to start beginning their resilience with. Lynn, does that answer your question, Lynn?
Yes, that's answer my question. So yeah, thank you. It's a good initiation for the future the resilience. Thank you.
I'll come in here. We have about 7 minutes. Just wondering, maybe we could, because I see a lot of interest, and that's really exciting for the team as well. Ashish, would you like to briefly talk about, the ways to get engaged with the TRC community to take this forward? Let me share my screen.
Thank you. So while Shilpa is getting ready to share the screen, what we really want to now focus on, at least for the next few minutes, is really, where is the value? How are we going to find mutual support and value as we continue talking about the work of resilience as the resilience collaborative? So what are those areas? So here are some ideas that we want to present to you. Sorry. And the idea from this slide really is to provoke some thought, and we invite you to share some ideas or your suggestions on the chat as well as I share this. So primarily the Resilience Collaborative's role is that of a platform or a facilitator, where we want to make sure that there is shared value or mutual value among the healthcare workers, institutions, and partners. The central column that you're seeing on the slide these broad ideas that we can begin to collaborate on. So the first one is professional networking or collaborations. And there could be many ways of offering mutual support to each other or engage in networking, with colleagues or with experts. But this is across the world. So we're finding ways in which many of our partners and colleagues are engaging in professional development. They're collaborating for projects or local initiatives. And if there are needs in different contexts, they're able to ask each other for help. Hey, how did you do this? How did you arrange for a session like this during a time of conflict or a disaster? How did you recover from? So there are many ways in which you could do this. And obviously, there are also opportunities for us to collaborate for funding or applications. So that is one cluster on the top. The second is resilience resources and programs, like this presentation is referring to. And these are resilience resources that we are collecting from across the world, from experiences from folks like you. And this could be in the form, as you can see, or a toolkit, or this could also be, so regional resilience practices that could surface when we start discussing like this about what is really working for people from the ground. Because of your experiences on the front line, there is certainly a lot of insight and experience. Sometimes it gets lost. And so we want to make sure that we can build that up, but also add a layer of peer support, having the support that Varadarajan was just mentioning, that once we have connections, we don't feel that level of isolation and loneliness, so that we can support each other effectively. And in that process also, many strong stories of resilience can surface. And those are really a point of encouragement for many of us. And as we just mentioned, we were also going to be taking this toolkit to Zambia, Lusaka, and we'll be happy to keep you posted with these things. The next element that is fairly important is about research and policy support. These are avenues to engage with issues that are really important or meaningful for you all from the ground, research that matters to you. And we particularly want to make sure that community health workers can participate and lead research and implementation efforts. And so you join in to contribute to your organization or to your country's policy and communicate that evidence in a way that supports multiple stakeholders. So at this point, we're working with a few associations to support health workers with their research needs in a worldwide group. Many of you are here who are part of the TRC leadership journey, which has the one-on-one support. So that's one cluster of opportunities. I'm going to rush through this, but please feel free to keep adding your ideas on chat. The next one down the line here is about referring or showcase your expertise. We are happy to invite you or have your colleagues invited for conferences or panels where you can share your experiences in your learning. And then finally, the element of governance and leadership. This is really crucial for community health workers because of your experience and exposure to be part of avenues where there's a way that you can shape governance, shape management, and decision making for your communities. One part of our work is the TRC leadership program that we have a group of about 11 people going through, and we're happy to extend that to many people, many of you who are here today, if this would be of interest to you. But those are broadly ideas, but we're happy to continue conversations beyond this presentation and speak further with you. So let me just give this back to Dr. Shilpa.
Thanks, Ashish. Thank you. So just again, feel free to type in as to what is one key takeaway from the session, and in any highlight would like to please type in the chat, and would love to hear from you. So we have just a minute more. So we also have another session on the CHW Symposium on 14th. Varadarajan and us would be presenting again, and then we will be covering other work, what we've been doing through the TRC. So the leadership program and some of the evidence-based work we've been doing as part of so please do join that session as well. It's in the Eastern time at 9 a.m. So please do consider joining, and then we're glad that many of the TRC members who have joined from the leadership cohort. So really glad you could meet today, and we hope that could also join on the 14th as well. So thank you for all of you joining. Really glad that all of you could join this session, and I see a lot of future collaboration. I think it starts off in a simple chat box in a meeting, and then I think years of collaboration which can start from here. So really looking forward to meet and probably collaborate with many of you to take this work on healthcare worker well-being. Thank you for joining.